Good evening, Joseph.
Yeah, good evening, sir.
Good evening, everybody.
Good evening. Shanawaz sir.
Good evening, sir.
Radhika, good evening.
Good evening, sir. Good evening.
വിജയ് രാധിക മാഡത്തിന് കോ-ഹോസ്റ്റ് ആക്കോ? എനിക്ക് ആക്കാൻ പറ്റുന്നില്ല.
So madam, good evening.
Sorry, mute ആയിരുന്നു. Good evening, Jose.
Good evening, madam. Good evening, madam.
Good evening, madam.
Good evening. Hello, good evening. ഞാൻ തിരുവനന്തപുരത്താ. ഞാനിത് കേരളം എന്ന് പറഞ്ഞുകൊണ്ട് കയറിയതാ.
കളക്ടറെ ഇൻഫോം ചെയ്തിട്ടുണ്ട് മാഡം. മാഡം
വരുന്നുണ്ടോ?
സാർ ചിലപ്പോൾ കയറുന്നു പറഞ്ഞു. ഗുഡ് ഈവനിങ് ആനന്ദ മാഡം.
സാറിനെ കൂടെ വിളിക്കൂ സാറേ. രാംലാൽ സാറിനെ വിളിക്കാൻ. നമുക്ക് ഒരു ചെറിയ ഇനോഗ്രേഷൻ കഴിയുമ്പോഴത്തേക്ക് എല്ലാവരും ബാക്കിയുള്ളവരും കയറി വരും.
Shanawaz sir, good evening.
Good evening, madam. Good evening.
Hello, madam. Good evening.
Good evening. അടുത്തിന് ഞാൻ ആദ്യം തന്നെ ഗുഡ് ഈവനിങ് പറഞ്ഞു മാഡം, അപ്പൊ കേട്ടില്ല.
അത് ശരി. ഞാൻ അവിടെ ഇല്ലായിരുന്നു, അതുകൊണ്ട് ഇന്ന് മറ്റേ മീറ്റിങ്ങിന് കയറാൻ പറ്റിയില്ല, കയറിയില്ല.
നമുക്ക് അത് കഴിഞ്ഞിട്ട് പ്രിൻസിപ്പൽ സെക്രട്ടറിയുടെ മീറ്റിംഗ് ഉള്ളതുകൊണ്ട് നമ്മൾ പെട്ടെന്ന് അങ്ങ്
അത് പറഞ്ഞല്ലോ, കഴിഞ്ഞ ദിവസം പറയണ്ടായിരുന്നല്ലോ എല്ലാ ദിവസവും ഉണ്ടെന്ന്.
Sir, good evening.
Joseph, good evening. Good evening. Shanawaz sir, good evening.
Good evening, sir. Good evening.
Girija madam, good evening.
Anita.
sir, good evening.
ബ്ലൈൻഡ്നെസ് ആണെന്ന് തോന്നുന്നു, എന്നെ മാത്രം കണ്ടില്ല.
ഞാൻ വരുന്നേ ഉള്ളൂ മാഡം. ഓരോ വരിയായിട്ട് തീർത്ത് വരിക. Good evening, ma'am.
Riyas.
Hello, good evening, good evening.
Good evening, good evening.
Riyas.
Good evening, madam.
Good evening.
Good evening to all. Parvati here.
Parvati madam. Good evening.
Good evening, madam.
Radhika, good evening. Good evening, ma'am.
രാംലാലിന്റെ മുന്നോടിയാന്ന് തോന്നുന്നു.
കിട്ടിയ ജോസറെ രാംലാൽ സാറിന് കിട്ടിയ
കിട്ടി. രാംലാൽ സാർ ഇപ്പൊ കയറുന്നു പറഞ്ഞു. ഒരു മിനിറ്റ്, കയറി കമ്പ്യൂട്ടർ ഓൺ ആയിക്കൊണ്ടിരിക്കാൻ കയറുന്നു. ഇപ്പൊ കയറുന്നു. ഗിരിജ മാഡം.
മാഡം ഇടയ്ക്ക് ജോയിൻ ചോദിച്ചാൽ മാഡത്തിന്റെ വീഡിയോ ആണ് ഓഫ് ആണ്.
മാഡം ഉണ്ട്. വിജയ് എവിടെയാണ്? വിജയ് ഉണ്ടല്ലോ അല്ലേ? വിജയ് ഓൺലൈൻ അല്ലേ? വിജയ്
ഉണ്ട് സാർ.
അപ്പൊ അഥവാ എങ്ങാനും ആരുടെങ്കിലും പ്രോഗ്രാം തുടങ്ങുമ്പോഴേ അൺമ്യൂട്ട് ആയിട്ട് പോകണമെങ്കിൽ അതെല്ലാം മ്യൂട്ട് ആക്കണേ, സൗണ്ട് വല്ലതും വരികയാണെങ്കിൽ.
ആക്കാം സാർ.
എന്തെങ്കിലും ഡിസ്റ്റർബൻസ് വരികയാണെങ്കിൽ. സുമാൻ സാർ, ഗുഡ് ഈവനിങ്.
പ്രോഗ്രാം കേൾക്കാന്ന് വിചാരിച്ചു.
വെൽക്കം സാർ, വെൽക്കം സാർ.
എത്ര മണിക്കൂറുണ്ടോ? 1 മണിക്കൂറാണോ?
1 മണിക്കൂർ.
സുമാന സാറേ നമസ്കാരം.
നമസ്കാരം ഷാനവാസ്. നമസ്കാരം.
One hour score, 9 o'clock time. Why?
സാർ ജോയിൻ ചെയ്ത ഉടനെ തുടങ്ങാൻ കേട്ടല്ല.
അതെ. ഒറ്റ മിനിറ്റ് സാറ്. രാമില സൂപ്രണ്ട്
സാർ. ഒരു ചെറിയ ഇനോഗ്രേഷൻ ഉണ്ട് സാർ. നമ്മളെ സീരീസ് ടോക്സ് ആണ്. അപ്പൊ പിന്നെ
ആണോ? അതിന് ഫസ്റ്റ് ടോക്കാണോ? അത്
ഫസ്റ്റ് ടോക്കാണ്. നമ്മളെ തേർഡ് വേവിന്റെ പ്രിപ്പയർനെസ് ഭാഗമായിട്ടുള്ള ഫാക്കൽറ്റി ട്രെയിനിങ് പ്രോഗ്രാമിന്റെ ഫസ്റ്റ് സീരീസ് ആണ്.
തേർഡ് വേവ്
തുടങ്ങിയല്ലോ.
ഇന്നത്തെ ട്രെൻഡ് കണ്ടിട്ട് തേർഡ് വേവ് നേരത്തെ വരുമെന്ന് തോന്നുന്നു.
തുടങ്ങി. ഇന്ന് 15,000 അല്ലേ? എനിക്ക് വേണ്ടി ഇറ്റ് വിൽ ബി എ കണ്ടിന്യൂഷൻ സെക്കൻഡ് വേവ്. കണ്ടിന്യൂ എനിക്ക് തോന്നുന്നു.
ഓണം വരെ കാത്തിരിക്കുന്നില്ലല്ലേ?
സെക്കൻഡ് വേവ് ഒക്കെ തുടങ്ങിയത് ബോംബെയിലാണെങ്കിൽ എനിക്ക് കേരളത്തിലായിരിക്കും തേർഡ് വേവ് തുടങ്ങണമെന്ന് തോന്നുന്നു.
അല്ല, മഹാരാഷ്ട്രയിലൊക്കെ ഇതിന് 3000 പേരേ ഉള്ളൂ. 1000. തമിഴ്നാട് അത്രയൊക്കെ ഉള്ളൂ. 3000 ഉള്ളൂ. നമ്മളല്ലേ 15,000. നമ്മളെ ടോപ്പ്.
എല്ലാത്തിനും ഒന്നാം സ്ഥാനമാണ് സാറേ.
ഒന്നാം സ്ഥാനം അല്ലേ? എനിക്ക് ഒന്ന് കണ്ടിന്യൂ ചെയ്ത് തോന്നുന്നു.
ജോസ് സാറെ ഒന്നുകൂടെ വിളിച്ചു നോക്കൂ സാറേ, എന്തെങ്കിലും കണക്ഷൻ പ്രശ്നം ഉണ്ടാന്ന്. നമ്മൾ തുടങ്ങിയിട്ട് സാറ് ജോയിൻ ചെയ്താലും മതി.
പ്രസാദ്, ഗുഡ് ഈവനിങ്.
സാറേ.
Shano sir, madam, Ananda madam, we will start the program. Okay, good evening to all. As part of our third wave preparedness pediatric faculty training program, we are going to start a series of, we are planning to conduct three series of faculty training program. The first program we are planning to start today. As you know, the anticipation of third wave, we are supposed to be more in pediatrics. That's why more pediatric preparedness needed for our third wave. I invite all of you to our series program. And now I invite Dr. Shanwas, HOD Pediatrics, to welcome to speak.
So very good evening to all. Respected Principal Dr. Sairu Philip Madam, DMO Alappuzha, Dr. Anitha Kumari Madam, Superintendent Dr. Ramlal Sir, Senior Faculties Dr. Suma Madam, Padmamar Sir, Sumaran Sir, and dear friends. We are anxiously expecting the third wave of Corona. So this third wave, we are expecting it will be affecting more of the children because of the lack of immunization to the children, and also relatively less exposure of the children so far, and they are more susceptible to COVID in the third wave. So in this context, we had a meeting of in Alappuzha with our district collector, DMO, and the faculties of Alappuzha Medical College, and we have decided a plan. We have planned for the we did a preparedness for that effective tackling of COVID. So we have decided to have a infrastructure development in almost all the hospitals, many main hospitals, like 5 Taluk hospitals, and including medical college. and also decided to conduct training program for all the faculties. So in this context, today we are going to have the first online talk that is on management of COVID newborns. So this will be continued in the next week with the respiratory management of COVID by Dr. Shija, and further by the cardiovascular management, and also COVID management, including MISC in the coming series. So after that, we are planning to have a online offline, that is hands-on training for those who need it. So I request Anita Madam to interest those who wants to have a hands-on training, and you select them and send to us in small batches, so that we will give a hands-on training to them. So my primary duty in this context is to offer the welcome to all the delegates. So first of all, I welcome our principal, Dr. Cyril Philip Madam, for this online meeting. Welcome you, Madam. And next, I welcome Dr. Anita Kumari Madam as our DMO. So she is taking very much interest in all the development of infrastructure management, and also infrastructure development, and also management aspects, including training. She has interested all the medical officers of health services to attend the course. So welcome you, Madam, in this meeting. And further, I welcome our Superintendent, Dr. Ramlal sir, for this session, for offering felicitation, and also our senior faculties, Dr. Suma Madam and Padma sir. I welcome both of you, sir. And further, I welcome IAP Alappuzha Academy Pediatrics President, Dr. And also Secretary for this session. So I welcome all the delegates to have a and for this session. So all my fellow faculties, and also all the delegates of the health services for this session. So welcome you all. Thank you. So over to Dr.
Thank you, Shanawaz sir. This is the program is jointly organized by Government Medical College, Department of Pediatrics and Government Medical Alappuzha, and the DMO Health Service and IAP Academy Pediatrics, together to conduct the awareness among the health service faculties, the medical college faculties, and even the private hospital faculty for we are interested for the COVID care management. So now I invite our principal in charge, Dr. Cyril Philip, to say a few words.
Respected Shano sir, esteemed DMO Anita Madam, senior faculty Padma sir, Suma Madam, dear Dr. Joe sir, and dearest Girija Mohan Madam, and my teacher T.U. Sugumaran sir, and all the esteemed senior faculty members of IAP, and all the senior colleagues in the District Health Services Alappuzha. I think the Department of Pediatrics, when there was a discussion regarding preparation for the COVID third wave, what I appreciated much was that their concern and concern for the little children if they get COVID. So they were so enthusiastic and took a lot of initiative to ensure that the children with MISC and others are treated properly. And I had conveyed that congratulations to Shanoa sir. And I think the pediatrics department always work in hands with the public health team in terms of national programs. So I'm so happy that this program has been realized. And I think this is one among the series of lectures that is to follow. And all felicitations for that. Thank you.
Thank you, Madam. And I invite our the District Medical Officer, Dr. Anita Kumari Madam, to say.
Thank you, Dr. Jose. Respected Sairu Madam, Suma Madam, Ramdal sir, Padma sir, and then Girija Mohan Madam, and sorry, Dr. Shanawaz, I missed him. Sorry, sir. and all the senior doctors and delegates who are attending this program. We have crossed nearly 1.5 years along with this COVID. Till now, we have 3,777 COVID positive cases in our district. When we look into the pediatric cases affected, in 2020 we had 8,897 cases, pediatric cases. That is up to the age group of 19 years. While in 2021, the case number increased to 22,938. In the third surge, if it happens, we are anticipating a pediatric surge. So we have started all level of preparations like infrastructure development, equipment procurement, and the most important among this preparedness is capacity building. And today we are stepping forward to the capacity building program. I hope it will be very much useful to our role of our doctors, including government and private sector. And my wholehearted felicitations to the program. Thank you.
Thank you, Dr. Ananda Madam. As Dr. Ananda Madam mentioned, we are on for the last 1.5 years, we are dealing with all the COVID management, major serious issues in Government Medical College under the leadership of Dr. Ramlal. Our superintendent given all hard support for all activities of COVID, even non-COVID cases also. So now I invite Dr. Ramlal to say a few words. Superintendent. Unmute sir, Ramla sir, unmute.
അപ്പോൾ എൻ്റെ ബഹുമാനപ്പെട്ട ധാരാളം ഗുരുക്കന്മാരെ ഞാൻ ഇതിനകത്ത് കാണുന്നുണ്ട്. വളരെ സന്തോഷം. പിന്നെ ബഹുമാനപ്പെട്ട നമ്മുടെ എൻ്റെ സുഹൃത്തുക്കളെ തന്നെയായ ഷാനവാസ് സാറ്, പത്മകുമാർ സാറ്, അനിത മാഡം, ജോസ്, സൈറു മാഡം, അപ്പോൾ അവരെല്ലാം കാണുന്നുണ്ട്. വളരെ സന്തോഷമുണ്ട്. പീഡിയാട്രിക്സുകാരുമായിട്ട് ഇടപഴകുമ്പോഴുള്ള എൻ്റെ ഒരു അനുഭവം എന്താണെന്ന് വെച്ചാൽ അവരൊരു ചെറിയ കാര്യം പോലും വിട്ടു തരത്തില്ല. ചെറിയ ഫൈൻഡിങ്സ് പൊക്കിയെടുക്കാൻ വിദഗ്ധരായവരാണല്ലോ പീഡിയാട്രിക്സുകാർ. അതുകൊണ്ട് തന്നെ പ്രിപ്പയർഡ്നെസ്സിൻ്റെ കാര്യത്തിൽ അവർ നമ്മളെ ഇടം വലം തിരിയാൻ സമ്മതിക്കത്തില്ല. അത് വേണം, അത് ചെയ്യണം. എന്നിട്ട് ഇങ്ങനെ നിതാന്തമായിട്ട് അത് ഫോളോ അപ്പ് ചെയ്യുകയും ചെയ്യും. അപ്പോൾ ആസ് എൻ അഡ്മിനിസ്ട്രേറ്റർ I have experienced that much of preciseness and preparedness. So first of all, I congratulate all of you that you are venturing the preparedness for the third wave. അതുകൊണ്ട് ഇതുപോലെയുള്ള എല്ലാ പരിപാടികൾക്കും എൻ്റെ ഹൃദയംഗമമായ ആശംസകൾ. നിങ്ങളുടെ കൂടെ സഹകരിക്കുന്നതിനും നിങ്ങളോട് കൂടെ ഈ പ്രിപ്പയർഡ്നെസ്സിൽ എൻ്റെ പങ്ക് വഹിക്കുന്നതിലുമൊക്കെ എനിക്ക് വളരെ സന്തോഷമുണ്ട്. അപ്പോൾ നമുക്കെല്ലാവർക്കും ഒത്തൊരുമിച്ച് ഈ തേർഡ് വേവിനെ നേരിടാൻ തയ്യാറെടുക്കാം. പിന്നെ നമ്മുടെ പ്രിപ്പയർഡ്നെസ് നമ്മൾ നന്നായിട്ട് ചെയ്തു കഴിഞ്ഞാൽ അത് തീർച്ചയായിട്ടും നമുക്ക് ഭാവിയിൽ എന്തായാലും ഉപകാരപ്രദമായിരിക്കും, കോവിഡ് ആണെങ്കിലും നോൺ കോവിഡ് ആണെങ്കിലും. അപ്പോൾ നമുക്ക് എല്ലാവർക്കും ഒരുമിച്ച് നീങ്ങാം എന്നുള്ള ഒരു സന്ദേശത്തോടു കൂടി നന്ദി പറഞ്ഞുകൊണ്ട് നിർത്തും. നമസ്കാരം.
Thank you, Ramla sir. Now we invite our HOD Medicine, Dr. Padmawar, to say a few words.
Thank you, Dr. Jose. Respected senior faculties and my dear friends. As we all know, this COVID is still an evolving disease, and the spread of the disease is in a wavy pattern. We know in 2020, when the first wave occurred, it mainly affected the elderly population who are having a lot of comorbidities and immunosuppressed. And the second wave, we saw that it mainly affected the young, healthy persons, maybe because of the mutations of the virus or many other undetected facts. So naturally, we expect that the third wave will naturally will more affect the children. That is why we are doing this preparedness, as Dr. Jose as well as Shanwasar has mentioned. What happened with the second wave was that there was a lot of lacunae in our managing the second wave, isn't it? We actually had a lot of celebrations and the election process and a lot of overconfidence from our side, and that created a lot of destruction in the COVID management side. A lot of young healthy adults were succumbed to death in the second wave. So naturally, we should have a very good preparedness for the third wave. And for that, this education is the most important thing, especially the clinical management of the cases, how to tackle critically ill patients, etc., is very important. So I think these Indian Academy of Pediatrics as well as the Department of Pediatrics of Alappuzha Medical College, with the help of this District Medical Office Alappuzha, has taken a very important step to educate the general practitioners as well as pediatricians working in this field to update regarding the COVID management of the newborn. So it is a very important thing. And I am always happy to know that IAP is a very active body, professional body, always active in such activities, including, as Sairu Madam has mentioned, community health activities also. So I wish this program will be very useful for the attending pediatricians, and I wish all the success for the program. Thank you. Thank you very much.
Thank you, Padma sir. Now we invite our Suma Madam to say a few words. Suma Madam, please. Suma Madam.
Thank you, Dr. Shanavas, Dr. Jose, Dr. Sairu Philip in charge of principal, DMO, Dr. Anita Kumari, and Girija Mohan Madam, Dr. Sukumaran, and other colleagues and friends. I'm so happy to be part of this the program, the medical education program, and also all the medical officers who have very enthusiastically joined this session from all the hospitals in and around Alappuzha, and Dr. Reyes and all the others. So this, when it was discussed about the third wave, the main thing was that it is going to be affected the pediatric population. And I know that from the beginning itself, pediatricians were given a lot of tasks, and also they wanted to take the burden on their heads. So it was also discussed that there could be some training program. Even though there was the NHM was conducting training programs, the Department of Pediatrics and the DMO's group has come forward to organize training programs for all the pediatricians and other medical officers of Alappuzha district. And I would like to congratulate the pediatric department to start this training programs, and also the DMO's team, because that coordination has brought this beginning of this continuing medical education program. And I also would like to welcome Dr. Radhika, who is going to present this session for today. And what I wanted to say is that this should be the best beginning for managing the third wave of the COVID, because we don't know how many waves will still be coming in. But for the third wave, probably it is now said that it may not be as severe as the second wave, but still the pediatrics, the Department of Pediatrics have taken a lot of effort. And also, when sitting in the district collectors meeting, I know that all the medical officers, pediatricians of the health services also were looking forward to arranging the infrastructure and all the facilities. I congratulate all of them and wish you all the best for this program and also the forthcoming programs. Thank you.
Thank you, Madam, for a nice words. Now I invite our association past national president, Dr. T. Sukumaran, to say a few words.
Beloved HOD of Pediatrics, Dr. Shanavas, and my beloved friend, Dr. Jose, Principal Dr. Sairu Philip, Dr. Ramraj, other dignitaries on the platform, and my dear friends. I am not supposed to give a felicitation for this meeting. I just ended the meeting to study something, to know about the neonatal COVID. I just ended, and Jose has asked me to just give a felicitation. I should congratulate the IAP Alappuzha. The President Sri Prasad is there, and the Department of Pediatrics under the able guidance of Dr. Shanavas, Srilada, Dr. Jose, and others, and also the hospital management for organizing this series of CME program on COVID. And I think this program is going to be very beneficial, not only for the academicians, practicing pediatricians, and also the postgraduate students also will be benefited from this series of talk. And I am very happy that Dr. Radhika is going to talk on neonatal COVID. And I suspect by seeing the number of cases today, it is more than 15,500 today. So has we started the third wave, or is it a continuation? The third may be a continuation of the second wave. I doubt. Still, cases are increasing day by day, and Kerala tops the list with the maximum number of cases. Even Maharashtra, Karnataka, and Tamil Nadu, the cases are around 3,000 to 2,000 solely. And so it is very, very important that we should give awareness for the problems of neonatal COVID and COVID in pediatrics, and early pickup and treatment of MIS-C also. And with this space, I wish this CME program all the best, and I once again congratulate the Department of Pediatrics and AAP for organizing this program. Thank you very much.
Thank you so much, sir. Regarding the COVID preparedness, all the program, Dr. Riaz from Trivandrum is always with has DME meeting and all coordinating of state level programs. Now I invite Dr. Riaz, Riaz to say a few words. Riaz.
Thank you, sir, for the invitation. വളരെ പ്രിയപ്പെട്ട ഒരു ടീച്ചറാണ്. അപ്പോൾ സാറ് ഇങ്ങനെ ഈ മീറ്റിംഗ് ഉണ്ട് കയറണമെന്ന് പറഞ്ഞതുകൊണ്ട് കയറിയതാണ്. ബേസിക്കലി പലരും പറഞ്ഞതുപോലെ ഇപ്പം സുകുമാരൻ സാറും പറഞ്ഞു, നമ്മള് കേരളം മറ്റ് സംസ്ഥാനങ്ങളിൽ നിന്ന് വളരെ ഡിഫറെന്റ് ആയിട്ടാണ് എല്ലാ സമയത്തും ബിഹേവിയർ ചെയ്തുകൊണ്ടിരിക്കുന്നത് ഈ ഹെൽത്ത് ഇൻഡിസസിന്റെ കാര്യത്തിൽ. കോവിഡിലും അങ്ങനെ തന്നെയാണ്. നമ്മൾ ഫസ്റ്റ് വേവ് വളരെ ഈസി ആയിട്ട് നമ്മൾ ടൈഡ് ഓവർ ചെയ്തു. പക്ഷേ സെക്കൻഡ് വേവിൽ നമുക്ക് പലതും പിഴച്ചു. പക്ഷേ ഇപ്പോൾ നമ്മൾ പ്രിപ്പയർ ചെയ്യുന്നത് എന്തായാലും തന്നെ നമ്മുടെ ഒരു തേർഡ് വേവിനെ നമുക്ക് ഫേസ് ചെയ്യാനുള്ള ഒരു വലിയ മുന്നൊരുക്കത്തോടു കൂടിയാണ്. അപ്പോൾ ഇതിൽ ഒരു കാര്യം, നമ്മുടെ ഈ ട്രെയിനിങ് ശരിക്കും നമ്മുടെ കോളേജിന് പുറത്തും പോകണം. അതായത് ഹെൽത്ത് സർവീസിലുള്ള ഇൻസ്റ്റിറ്റ്യൂഷൻസ്, നമ്മുടെ അടുത്തുള്ള പ്രൈവറ്റ് ഹോസ്പിറ്റൽസിലെ ഒക്കെ ആളുകൾക്ക് നമ്മൾ എംപവർ ചെയ്യുകയും നമുക്ക് ഒരു അഡൾട്ടിന്റെ സമയത്ത് വന്നതുപോലെ ഒരു അഡോളസൻസും യങ് ചിൽഡ്രനും കഷ്ടപ്പെടാൻ ഉള്ള ഒരവസ്ഥ ഉണ്ടാകാത്ത രീതിയിൽ നമുക്ക് ഹോസ്പിറ്റൽ ബെഡ്സ് ഫില്ലാവാതെ നമ്മളൊരു ഷെയർഡ് കെയർ എന്നുള്ള രീതിയിൽ നമുക്ക് മുന്നോട്ട് പോകണം. അതാണ് ഈ ട്രെയിനിങ് പ്രോഗ്രാമുകളുടെ എല്ലാം ഉദ്ദേശം. അതിനു വേണ്ടിയിട്ട് ജോസ് സാറും ഷാനവാസ് സാറും അതുപോലെ തന്നെ ആലപ്പി ടീം, ഇപ്പൊ സുമ മാഡം നമ്മുടെ ഇതിന്റെ ഒരു സ്റ്റേറ്റ് ലെവൽ എന്താ പറയാ ഒരു ലീഡർ തന്നെയായിരുന്നു ഈ കോവിഡ് ഫൈറ്റിൽ. സന്തോഷ് സാർ എപ്പോഴും മാഡത്തിന്റെ ഇത് പറയുമായിരുന്നു. അതുപോലെ രാംലാൽ സാറ് ഞാൻ ഓർക്കുന്നത്, നമ്മള് കോവിഡ് തുടങ്ങിയ സമയത്ത് അവിടെ ഒരു മീറ്റിംഗ് ഉണ്ടായിരുന്നു. അപ്പൊ അന്ന് സാറ് പറഞ്ഞ ഏറ്റവും പ്രധാനപ്പെട്ട കാര്യം നമ്മള് ബാക്ക് ടു ബേസിക്സ്. അന്ന് സാറ് ഈ ബാക്ക് ടു ബേസിക്സ് ഒക്കെ സ്റ്റേറ്റ് ഗവൺമെന്റ് പറയുന്നതിന് മുമ്പേ സാറ് പറഞ്ഞു ഹാൻഡ് വാഷിംഗ് ആണ് ഏറ്റവും ഇമ്പോർട്ടന്റ്, മാസ്ക് ഇടുന്നതാണ് ഏറ്റവും ഇമ്പോർട്ടന്റ്. അത് എപ്പോഴും ഓർക്കുന്നുണ്ട്. അപ്പൊ ആ ഒരു ബേസിക്സുമായിട്ട് നമ്മൾ മുന്നോട്ട് തന്നെ പോകട്ടെ. എല്ലാ ആശംസകളും നന്ദി.
Thank you, and thank you, Riaz, for the nice words. And now you are concluding the this inaugural function. I request our IAP Alappuzha branch president, Dr. Sri Prasad, to report of thanks, and after that we will go into scientific program. Dr. Sri Prasad, please.
Thank you, Joseph. So on the behalf of IAP Alappuzha, we are expressing our sincere thanks to Dr. Sairu Philip Madam, Principal in Charge. Our sincere thanks to Anita Madam, our beloved DMO. We are so thankful to Ramlal Sir, Superintendent, TD Medical College, Vandanam. We are so thankful to Padma Kumar Sir, HOD Medicine, and Suma Madam. We are expressing our sincere acknowledgement to Shanavas Sir and Joe Sir for moderating the sessions. And our sincere thanks to Dr. Radhika. We are expecting a very lucid presentation from you, Madam. Also sincere thanks to Sukumaran Sir, Girija Madam, Riaz Sir, and to all medical officers from Kerala State Health Service and Alappuzha Academy of Pediatrics for attending this academic session. Thank you.
Thank you, and thank you, Sir Prasad, for that. What a thanks. And now we are concluding our inaugural function. We are going to scientific program. Now I invite Dr. Shanavas to introduce Dr. Radhika and for the topic, and introduce Radhika to the audience.
So, good evening to all. So again, welcome to our first talk of the pediatric preparedness of COVID. So as we all know, So when we consider about pediatric COVID, we should start with our newborn. So regarding in TDMCH last year, the second wave itself, we have got more than 400 deliveries of mothers of COVID positive, and we had only very few patients, very few newborns with the COVID positive, and we had there is no death of COVID newborns. But we had 2 deaths that who are having COVID positivity, but both of them are not due to primary COVID. One is due to a DiGeorge-like syndrome. One is a case of birth asphyxia. So only 2 deaths in COVID positive babies, and it is due to it indicates that this not, even though COVID positive mothers are very common, the COVID illness is not very severe, especially even in newborns. But all the literature shows that there is about around 2, I think 1 to 2% of the COVID newborns can have severe COVID disease and pneumonia. They may need even ventilation and other therapies also. So to enlighten us on this topic, we have got Dr. Radhika as a faculty. She's currently the HOD of neonatology unit of TDMC in Government Medical College Trivandrum, and where there is she's effectively leading the DM course in neonatology also. So she did her MBBS and DNB from Government Medical College Trivandrum, and did his DNB in neonatology from KIMS Hospital. And after that, she is working for the last 10 years in the Government Medical College Trivandrum itself as a neonatologist. So I hope this topic will be very much interesting. And I welcome Dr. Radhika for this session, and give the platform to Radhika. Over to Radhika for your presentation.
Thank you. Thank you so much. Am I audible?
Yeah, audible.
Screen is visible?
Yes, visible.
Thank you so much. I would like to express my gratitude to the organizers, my teacher Shanavas sir, then Joe sir, and all IAP Alappuzha and all the organizers for giving me this opportunity. So the references that I will be quoting while we are getting ready to prepare for management of neonates in the current global pandemic of COVID, we will be quoting the perinatal and neonatal management guidelines given off by NNF and FOGSI, which came in 16 June 2021, and also the latest Government of Kerala guidelines for preparation of management of surge, again, which is this document was again published in 2nd of June 2021. So these will be my references for the talk today. So we all know that we are now in this preparation stage for what is yet to come, and it is always better to be prepared for an emergency, and hopefully we will be well prepared, but we will not have to face the worst. That is what we are aiming for, but it is always better to be prepared. Now, coming to the talk, now what we have seen a marked difference in the in the outcome of pregnancies in the first wave and the second wave. In the first wave, even though there was a lot of morbidity and mortality among various adult population, what we have been seeing is during pregnancy, the test positivity rate among hospital women, where there was a universal screening for COVID-19 being done, varied from 5 to 12%, and only around less than 10% of these positive women were symptomatic. And fortunately, during the first wave, hardly less than 2% of these pregnant women in the antenatal period had moderate to severe illness due to COVID. But the second wave, the picture has changed. The test positivity rate among pregnant women has increased to about more than 20%, and symptomatic women also increased to 50%, and we are seeing about 1/5 or 20% of them having moderate to severe illness. So there is a change in the manifestation of the COVID infection during pregnancy. We are already know that the neonatal population is a very vulnerable population, and to various infections. So what is the effect of this COVID-19 on the fetus? The studies done so far has not reported any increased risk of teratogenicity, but further follow-up and studies may be required due to the presence of the COVID-19 infection in the mother in the first trimester. But there is a worry that many of the drugs which are used for the mother for treatment of COVID, like doxycycline, ivermectin, may have, or high dose of vitamin D, may have teratogenic potentials, but we don't have any data regarding the same. And only as the disease evolves and time comes, we will be able to talk about that. There has been reports of significantly increased risk of stillbirth and intrauterine growth restriction. Now, coming to the effect on the neonate, so far what we have been seeing, and from reports world over, there is a small risk of vertical transmission, but it is low. The rates of transplacental transmission can vary from 0.5 to 13% with a median of 2%. And there was a multicentric trial done by NNF in the COVID registry, and they also have reported the initial vertical transmission rates among neonates to be less than 10%. There have been significant increase in prematurity and low birth weight and higher neonatal morbidity index. But as Shanava sir was saying, even though we are seeing positive babies, there is no statistically significant effect on the neonatal mortality due to COVID. The various modes of transmission which are thought to be there, and one is the intrauterine transmission due to transplacental passage from the mother to the fetus, or it can be direct exposure at the time of delivery due to the exposure to the maternal blood or secretions, which is the intrapartum infection. And what is commonly seen among all these is the postnatal transmission through aerosol or direct contact by affected family members or even healthcare professionals. That is the postnatal infection. These are the various modes of transmission that have been reported. So what do you count? There's a lot of confusion on what does actually perinatal transmission mean. So it has been defined as a positive RT-PCR in the neonate in the first 3 days of life for the first 72 hours. And this may be due to either intrauterine or intrapartum transmission. And horizontal transmission is the one that is acquired postnatally. And the baby may be initially negative, but later on, due to close contact with other positive family members or healthcare providers, they become positive after 72 hours. So this is a rough definition of what is the perinatal transmission and the horizontal transmission of COVID. Now, coming to the antenatal period, I'm not going into the details of management of the pregnant women, but what is important for the baby is whether in a preterm delivery, they know the norm is to give antenatal steroids for all pregnancies when less than 34 weeks of gestation. And the same practice should be continued irrespective of the COVID status of the mother. And it has been recommended that dexamethasone 6 milligram IM 12th hourly 4 doses be given. But if for any reason the mother has a maternal COVID illness requiring steroid therapy, this antenatal steroids can be followed by either methylprednisolone or prednisolone or hydrocortisone for more days or discharge as per the mother's symptom. But the protocol for antenatal steroids remains the same and has not changed. And whether steroids need to be continued due to maternal illness depends on the case-to-case basis. Otherwise, recommendations are the same. Now, when do you suspect COVID-19 infection in a neonate? So any baby who is born to a mother with COVID-19 who is diagnosed 2 weeks before or within 2 days after delivery is what the new guidelines given by NNF says. A mother who is born to a suspect COVID-19 who is symptomatic, or a postnatal exposure to another person who has symptoms consistent to COVID-19. And it can also be any other, there may not definitely be a history of contact, but a baby who presents beyond 48 hours of life and present with respiratory symptoms, with fever, seizures, or it can be varied presentation where you're not able to find a definite cause and sepsis has been rolled out. In this current situation, you should always think of COVID as well. So how do you confirm? Definitely for confirmation, you need a lab test, an RT-PCR, or that positive may be required. And even if the initial antigen testing is negative, if there's a strong clinical suspicion, definitely we should do an RT-PCR for confirmation of diagnosis. Now, coming to the management in the labor room, and as we have been going through the pandemic so far, I'm sure this setup is there in almost all centers delivering babies, mothers who are having suspect or confirmed COVID. There should be a separate delivery area and a separate operation theater room. And as per the normal protocol of fetal monitoring during labor should continue. There is no evidence to suggest that one mode of delivery, whether it should be a vaginal delivery or a cesarean section, or in case of a COVID positive mother, and it should be as per the obstetric indications. Only if there is a need to, based on the mother's comorbidities or any other obstetric indication, should you prefer cesarean section. But COVID per se is not an indication for cesarean, and it can be decided by the obstetrician. And whether you should bring out the baby early, there we have seen a number of increase, especially in the second wave, increased prematurity because of the maternal illness, and pregnancies have to be terminated early because of the mother being ill due to moderate or severe illness and requiring respiratory support. So based on the mother's illness,
Radhika madam, action boya Radhika madam. I think
100 participants ആണ് അപ്പം ഒന്ന് ക്വിറ്റ് ചെയ്യേണ്ടി വരും.
അല്ല കുഴപ്പമില്ല, ജോയിൻ ചെയ്തിട്ടുണ്ട്. രാധിക ജോയിൻ.
മ്യൂട്ടാണ് രാധിക, മ്യൂട്ടാണ്.
Mute.
I'm sorry, I think my network had a small problem. I'll start sharing again. Sorry about that. Share screen വന്നായിരുന്നു.
Yeah, വന്നു. Change to slide show.
Slide show ഇട്ടാ മതി. Slide show ഇട്ടാ മതി.
Okay.
So where I stopped was in the antenatal management, the decision of timing of the delivery and the mode of delivery is as per the obstetric indication and the illness of the mother. In the resuscitation area for the neonate, it should be either in a room that is adjacent to the delivery area, or it should be in the same room and at least 2 meters away. And if there is a separate curtain to separate the area also, because to reduce the risk of aerosolization, you can have a separate area. All the resuscitation equipment should be the same as you would do for any other area. And you need separate personnel to attend these deliveries. And for a low risk delivery, minimum number of person, 1 person should be sufficient. But a high risk pregnancy, at least 2 people to attend the delivery. Personnel should follow all personal protection precautions while attending the delivery. There is nothing specific in the neonatal resuscitation guidelines, but any procedure that can cause aerosolization should be limited, and bag and mask can follow the routine procedure if it is indicated. And unnecessary suctioning, oral or nasal, should be avoided unless otherwise indicated. And also administration of drugs through the endotracheal tube should be avoided. Now, the practice of delayed cord clamping, all the new guidelines have advised delayed cord clamping and early skin-to-skin contact, even in mothers who are COVID-19 positive. But sometimes we face that doing this may be practically difficult in most of our wards during the COVID situation. But the current guidelines does recommend for continuation of the practice of delayed cord clamping and early skin-to-skin contact. And once the baby is delivered, if the baby has to be transported to another area, you can, if you have a transport incubator is available, that should be ideal. Otherwise, an open infant carrying bassinet covered by a cling wrap can be used. Now, where do you keep this baby? Now, the baby, if the mother and baby are healthy, they should be roomed in together and kept away in a separate isolation area from uninfected mothers and babies. And exclusive breastfeeding can be promoted, but the mother should follow all the respiratory etiquettes, wear a N95 mask, and also follow all the hand hygiene precautions. And at the time when the mother is not breastfeeding, a healthy caregiver can take care of the baby and can keep the mother and baby at a distance of 2 meters away. So this is what is being practiced now. This is again a pictorial representation of the same. So even COVID positive mother and baby, there is no need to separate them if both are well, unless they are symptomatic or sick. Otherwise, they can be kept in the same room. Breastfeeding can be continued, and at other times, they can entrust a healthy caregiver. But the practical difficulty sometimes we face is, where is this healthy caregiver? What is described as a healthy caregiver is somebody who is less than 60 years of age, who does not have any other symptoms or comorbidities. But what we are seeing now is many times in all families, the mother is affected, so is the grandmother, so are other relatives. So it is very difficult to get this healthy bystander to take care of the baby, and that is one practical difficulty that we face in most times. Now, suppose the baby is symptomatic, or it is a preterm baby less than 34 weeks who requires an admission for an separate admission, we have to arrange a separate isolation SNCU. So that is what we are doing. You need a ward where the healthy mothers and babies are kept, and babies who are symptomatic due to other reasons or due to prematurity, we are admitting in the separate SNCU. This is the suspect cases who are not yet confirmed to be COVID-19 positive. So who all are admitted in the suspect ICU? Who are babies who are born to mothers with suspected or confirmed infection, there is a postnatal infection, or the baby is being referred from another area and the mother's results are unavailable, or the baby is showing some signs and symptoms, but we don't yet have the results. So you cannot admit such babies in the common neonatal ICU unit, and you need a separate ICU to take care of such babies. Now, in any situation, if the baby is sick, of course, the baby needs this ICU care. And if the mother is sick, it depends. If there is a healthy caregiver, the baby can be cared for by that in a separate isolation area, and there can be given expressed breast milk. Now, coming to breastfeeding, we know that all studies have shown that the presence of the SARS-CoV genome in the breast milk is uncommon, and when it does occur, it is usually associated with mild symptoms. So, and also the baby gets the protection of the antibodies which are prevalent in the breast milk. So considering the benefit and risk ratio, breastfeeding is definitely recommended and should be continued. If there is a risk of transmission, it is usually due to the droplet infection. So while breastfeeding, the mother should wear a mask and should follow all hand hygiene preparation. So all the etiquette of avoiding coughing, sneezing, or again, this should be taught to the mother and a healthy caregiver. And in case she is not able to do direct breastfeeding, she can be asked to buy a breast pump or express the breast milk, and this should be carefully transported without any contamination. And in case only in situations where direct breastfeeding is not possible and express breast milk is not available, then we have to resort to formula feeding after proper education. So a breast pump, a dedicated breast pump for mothers who are COVID positive is a good investment, and they need a strict adherence to all sterile precautions while it is being used. Now, how early do you test these babies? Normally, the routine time for testing is by 24 to 48 hours after birth to look for intrapartum transmission. And in the first day, if you test too early, like in the 12 hours, there is a high risk of false positives. So because of certain superficial colonizations. So the ideal time for testing of a neonate born to a COVID positive or suspect mother is by 24 to 48 hours of life. And suppose the baby has has come in contact with a high risk person or a COVID positive, but the baby is asymptomatic, then postnatally, within 5 to 10 days of coming in contact, we can do a RT-PCR testing. But if a baby is symptomatic at any point of time, you can do the testing at the time of first evaluation. So if you're looking for intrapartum transmission, the timing of testing is by 24 to 48 hours. And postnatal transmission, if the baby is symptomatic, you do the testing straight away. Asymptomatic, you wait for 5 to 7 days for doing the testing. And of course, with the recommended test is the RT-PCR by a nasopharyngeal swab. And the method is now well known to everybody. We insert the adequate swab parallel to the palate, and they take the distance from the nostrils to the outer opening of the ear, leave it for a few seconds to absorb the secretions, rotate it, and gently remove it. And it is transported in the transport media. In a case of a very sick neonate, and if the baby is intubated, tracheal aspirate may also be sent for testing. Suppose it's an emergency and you need to triage the baby, and we can do other tests like a TrueNat test or a rapid antigen testing. But even if the antigen testing is negative, as I said earlier, it needs to be confirmed by RT-PCR. Routine serological testing with COVID IgM or IgG antibodies is not usually recommended. Am I clear? Is there any net connectivity issue?
No, clear and audible.
Clear.
Okay, thank you, sir. So what do you do once the test result comes? If the test is positive and the baby is sick, of course, you have to admit in the COVID ICU. And what we have in our hospital is we are having a common pediatric and neonatal ICU where neonatal warmers and are kept. So there's a COVID positive baby symptomatic, we admit to the COVID NICU. And if the baby is positive, but he is stable and asymptomatic, we shift back to the mother's ward and keep the baby under close observation. So in an asymptomatic baby who is positive can be with the mother, but if he is sick or symptomatic or preterm, the baby needs to be admitted to the COVID NICU, which is for positive babies. So the difficulty in logistics for arranging the different areas when you're planning is you need a ward for positive babies, you need an NICU for suspect sick babies, and you need an NICU separate for the positive babies. So resources, manpower for all these areas need to be shared, need to be decided upon. So that is where our main logistical problems come. Now, if the baby is negative, then you can give the baby to the mother if non-sick or to a healthy caregiver. Is there any need to retesting? Now, for a newborn baby, just like we do for pediatrics, there is now the current guidelines is there is no need, even if the initial test is positive, there is no need for routine repeat testing of the baby. The baby can be discharged along with the mother, and you keep a close follow-up and ask them to report if the baby is showing any signs and symptoms and continue the normal home quarantine or isolation protocol. And if the test is negative, again, there is no need to test unless the baby is showing any signs and symptoms which is consistent with COVID. Now, suppose you are admitting this baby into your COVID SNCU, and the initial test is negative, but the baby continues to be symptomatic for any other reason. Maybe it's a preterm baby. Then if you want to shift this baby to a common NICU care area, you need 2 negative results. Even the first result is not sufficient. So if there is any plan, you are not able to discharge the baby and the baby needs prolonged hospitalization, before shifting the baby to a common neonatal area, one more testing after 5 to 7 days is required. So only with 2 negative test results, you can shift this baby to a common NICU. Now, another problem that we see is sometimes the babies in the postnatal wards or in a separate room can become positive. The baby may become positive, or it may be another mother who is positive. And this also, if the baby is stable, you can discharge the baby. If the baby becomes symptomatic, then you can do the testing. Asymptomatic high-risk contacts, we usually advise testing after 5 to 10 days. And you cannot shift these babies to another common area because they have come in contact with a high risk or a positive mother. So they will have to be either discharged home or kept in that isolation for at least 2 weeks. So this is another problem that we often face, is another mother or another bystander in a common neonatal area becoming positive. So these babies do become a high risk contact. So we need to keep them under isolation and test them if they become symptomatic. Now, coming to a few words about the neonatal COVID infection, again, we said an RT-PCR is required. And how do you care for these positive babies? Ideally, you need a separate ICU, and if a negative pressure ICU is available, it can be used because especially in procedures that require aerosolization. And if it is not available, a negative pressure can be created by using 2 to 4 exhaust fans, which drives the air out of the room. And of course, central air conditioning should not be used. So you need these designated areas, and between two radiant warmers, at least 2 meters difference should be kept. And you need a dedicated staff, pediatrician, and with adequate personal protection equipment to be taking care of such babies who are positive, admitted to the COVID NICU. Luckily, what we have seen so far is a majority of our positive babies remain asymptomatic or have only mild symptoms due to COVID per se. And only a few, less than 10 to 15% may develop moderate to severe symptoms, including respiratory distress, lethargy, poor feeding, or shock. So this is a new guidelines classifies the severity of illness in neonates into mild, moderate, and severe. First one is mild fever, rhinorrhea without any respiratory distress. Moderate is presence of tachypnea with a respiratory rate of more than 60 or a saturation falling with and the severe sign can be signs of hypoxia with a SpO2 below 90. It can be it can be varied presentation. It can be apnea, it can be shock, it can be multi-organ involvement, it can be thrombosis, it can be varied. So the severity of illness in neonates, even though it is not very high, it can have a varied presentation. Now, what is a major worry, because we are seeing the multi-system inflammatory syndrome in children, what is the case in neonates? Even though this is not well recognized, there are more and more case reports being reported from various parts of the world of this new entity called MISC-N. It is a neonatal hyperimmune response to the antibody or the maternal IgG SARS-CoV antibody that are transferred from the mother to the baby across the placenta. And the baby may initially, without showing any other signs, they may become critically ill with multi-organ dysfunction, and the baby's presentation may be as a myocarditis, DIC, conduction blocks. It can be respiratory distress, diarrhea, NEC, or thrombosis. So this is a varied presentation, and there have been reports coming out of the same. And there is a case series which was reported from Kolhapur in India of 20 neonates, and this is the criteria they used for diagnosis of MISC in neonates. So any neonate less than 28 days at the time of presentation with a history of a lab or evidence of SARS infection in the mother, past infection in the mother, and the serology testing positive for IgG, symptoms, any past history of SARS infection during pregnancy, or a contact with a COVID-19 positive person. The clinical criteria is severe illness needing hospitalization, and we said any multi-organ involvement, and a lab evidence of elevated inflammatory markers like a CRP, ESR, second tier investigations like fibrinogen, D-dimer, ferritin, etc. And in a neonate, you always have, because it can overlap with other neonatal conditions, you have to make sure, because the more common cause in neonates to be sick will definitely be bacterial sepsis. So make sure you have ruled out bacterial sepsis, or there is no birth asphyxia or no other illnesses before you consider the diagnosis of neonatal MISC. So if the baby is positive, but the baby is not symptomatic, there is no need for any laboratory investigation. For babies with moderate or symptoms, you can do the basic first tier investigations, including a blood count, CRP, liver function test, and showing respiratory distress, a chest x-ray. The classical findings in a symptomatic COVID positive babies, as in a pediatric age group, include leukocytosis with lymphopenia, thrombocytopenia, hyponatremia, hypoalbuminemia, and elevated CRP or ESR. This is what is seen. And only if the baby is becoming sick or showing any multi-organ involvement, you go for your second tier investigations, which include cardiac markers, ECG and echo, ferritin, interleukin 6, LDH, a coagulation profile, and serology. Routine serology testing is not done, but multi-organ involvement, we do mothers and babies serum, IgG and IgM for SARS-CoV-2. So this is the paper came out recently, and this is the 20 cases which was reported in India. Mothers who had a past history of COVID-19 infection, and the IgG was positive in 19 of them. Mothers were mainly asymptomatic at the time of delivery, and it was a previous infection that caused the transplacental transfer of these antibodies. A majority presented with a cardiac illness, followed by others respiratory, DIC, feed intolerance, and they had a mortality of 2 neonates. So there is this, definitely there are more and more reports coming from various parts of the country and the world. So probably with the in the coming future, with many antenatal mothers being exposed to COVID, and this is an entity that we are likely to face, and we should be prepared for, and we should keep in our mind when other diagnosis has been ruled out. Management, again, you need a tertiary care hospital to manage such neonates. Multidisciplinary approach is required, and you may require to extrapolate from pediatrics and use many of the drugs that are being used in pediatric MISC as well, even though current guidelines are not are saying which is better than the other. What is the respiratory support required for a neonatal COVID infection? If the baby is having minimal distress and when the saturation is falling below 90, you can use a low flow nasal cannula, keeping the oxygen concentration below 2 liters per minute. And the targeted saturation, you prefer the preductal, that is the right upper arm saturation of more than between 90 to 95 is required. If the baby is having moderate to severe, based on the condition and the expertise available, you can either use a CPAP or a HHFNC or a non-invasive ventilation. And as per the indications, you may go for early mechanical ventilation. Aerosolized generating procedures like nebulization and open suctioning should be avoided as far as possible, and if you can have an inline suction, that is the best method. So this is the respiratory support in a neonate. Now, the previous guidelines, we were not facing many very sick neonates, so the routine recommendation of antivirals, chloroquine, and drugs which were prescribed for adults were not recommended in symptomatic neonates who had COVID-19. But now we are seeing certain conditions like the severe COVID pneumonia or a MISC-like presentation. So we extrapolate whatever evidence we are getting from pediatrics, and steroids have been tried after the initial reports of viremia. So babies who have mechanical ventilation and sepsis has been ruled out. What is recommended is a dose of dexamethasone 0.15 milligram per kg, OD dosing for depending on the clinical course for 5 days to 14 days. And other alternatives, hydrocortisone, methylprednisolone can also be considered. And in preterm babies, more reports are there of preferably using hydrocortisone over dexamethasone, because there is always postnatal exposure to steroids are usually there is a risk of long-term outcomes and neurodevelopmental outcomes. So seeing the risk-benefit ratio, we have to decide and counseling the parents whether systemic steroid should be used or not. IVIG infusions, slow infusions are being given. There have been case reports that when there is echocardiographic evidence of a cardiac involvement like shock or an LV dysfunction or a coronary artery abnormality, then you might consider giving IVIG. And other antivirals have not been recommended. This is the case report that was came out again, which showed a baby presenting with an ischemic limb. And I think a similar presentation I have seen from Kozhikode Medical College also. also, where a neonate was born with an ischemic limb and the serology for COVID-19 was positive. So reports of rare presentations of COVID-19 are also coming up. And in such situations, low dose aspirin or enoxaparin may be considered only in such critically ill neonates with close monitoring of the coagulation profile. Especially in preterms, there is a risk of intraventricular hemorrhage. So we have to have a definite confirmation before we decide on these treatment modalities. Now, coming back to a few of our logistic issues. Now, our routine policy in the NICU before this COVID pandemic was involvement of the mother early in the care of the newborn. Mother used to come very frequently to visit the baby, start kangaroo mother care, start early initiation of non-nutritive sucking. But the COVID pandemic, this has taken a heavy toll because a few of our mothers who visited the NICU later turned to be positive. So there is a risk definitely for this. So if the mother is positive, at least if she's critically ill, she should wait for 20 days, otherwise 10 days till the resolution of symptoms or without fever. And after that only we should allow the mother to visit the NICU. And she should follow strict respiratory precautions, wear an N95 mask. We are insisting on the face shield and other precautions, hand hygiene as well. How long should the mother who is positive maintain all the COVID prevention protocol before she handles her baby? We said breastfeeding can be continued, but at all other times, respiratory precautions should be followed. If she has a mild disease, if she is afebrile for 72 hours without any use of antipyretics, and after 17 days of onset, that should be okay. If it is a severe illness, 20 days is what is recommended. Again, another logistic issue is cleaning and disinfection of all the equipment that are used because of other risk of transmission of infection, neonatal sepsis. The personnel who is cleaning the equipment should wear a PPE. And if any surface equipment is visibly soiled, first we clean with soap and water solution and then apply the disinfectant. Bleach hypochlorite solution for large surfaces like floors and walls. Spirit can be used for reusable probes and other equipment. And if you want to clean radiant warmers or other syringe pumps and other equipment, when they are not being used, we prefer use of hydrogen peroxide for surface cleaning and allow a contact time of 1 hour. This is only when the equipment is not being used for the baby. Now, coming to pre-discharge screening, the government is going in a big way in doing pre-discharge screening in many modalities for the newborn baby, which included NBS. But because in what we are following is because in our hospital, this is done in a common area and we are having practical difficulties in doing NBS for the COVID positive babies, we are doing a cord TSH or thyroid screen, which is definitely a must. We are doing for all these babies, and they are asked to come back after their isolation period to complete the rest of the testing. Pulse oximetry screening is done in the COVID ward itself by doing the preductal and postductal saturation, and you need a dedicated pulse oximeter for that. Hearing screen, again, we are giving them a date or giving them the number to call up, and either they can go to another local hospital or where the OAE screening will be done, or they can come back to our institute and it can be done, but we should make sure they do not miss out on any of these important screening programs. So some of the problems we face is continuing of our normal pre-discharge screening, but we make sure that we give them an appointment date and they come back for the screening as soon as their isolation period is over. Immunization, we should follow all routine immunization policies in COVID babies as well. The BCG, OPV, and the birth dose hepatitis can be given. But if the baby is symptomatic or sick, we usually ask them to wait till 2 weeks, come back after the isolation period to give the BCG and OPV. But the zero dose hepatitis B can be given even while the baby is admitted in the SNCU. What is the discharge policy? If the baby is symptomatic, we wait till at least 72 hours after resolution of symptoms. Routine retesting for mild symptoms is not recommended, but if the baby is critically ill, we can do a testing before by RT-PCR before or antigen testing before hospital discharge. If the baby is positive but he is not showing any signs and symptoms, there is no need to retest, and when you can discharge or even after 48 hours, along with the mother, these babies may be discharged and home quarantine can be followed. Many times we find that the baby is asymptomatic, but the mother continues to be sick. So if such situations, prolonged hospitalization for the mother may be required. So the baby may be discharged if a healthy caregiver is available and there is no facility to keep the baby within the hospital. Prior to discharge, it is important to ensure, because we are again in the breastfeeding revamping, and COVID should not affect our breastfeeding rates. So we have to ensure that breastfeeding is established. Look for evidence of jaundice or explain the danger signs clearly, and when tell them what are the symptoms they have to look for and when they have to come for follow-up. It will be good to give a phone number to share for them to call back. And the new guidelines definitely say that all neonates who are born to COVID-19 mothers should be followed up in within 2 weeks, and continue to keep them under follow-up, because we don't know what is evolving. This was a paper that we presented in one of our DM residents had presented after the first COVID wave. I'm sorry for the busy slide. When the first wave, we had about 312 neonates born to mothers who are COVID positive, with 13 of them becoming positive, and with a test positivity rate of around 9%. But if you, that is both inborn and outborn, if you look at our inborn rate, it was around 4%. And in the second wave, we are now analyzing this. More and more sick babies are being born because of prematurity, because the mothers are symptomatic and they require care in the COVID SNCU, because more and more mothers are delivering prematurely, and thus the babies are sick due to prematurity. None of the babies, due to our early transmission or within the 48 hours who became positive, became sick. They were either asymptomatic or had only mild symptoms. I'm just highlighting two difficult cases. These were the only two difficult cases that we had due to COVID in the second wave. The case A was a preterm baby who was one of the twin, and the baby was discharged initially on the 15th day. After 1 week, the baby was readmitted with history of respiratory distress and poor activity, and the baby, and we saw the baby became apneic and soon had to need respiratory support. The TrueNat of this baby was positive, and the baby had leukopenia, thrombocytopenia, hypoalbuminemia. The chest X-ray progressively worsened with bilateral fluffy opacities, and baby required invasive ventilation. Baby's echocardiography was normal, and other causes of sepsis were ruled out. This was a preterm baby, so we went for hydrocortisone, started on broad spectrum antibiotics. And at that point of time, because evidence was not available, this was sometime in April, IVIG was also given for this baby, and we asked our infection control specialist, and because of certain other case reports showing the use of remdesivir at that point of time, we tried it, but we did not get much benefit. And unfortunately, this preterm baby, after a prolonged hospital stay, expired on day 38 in spite of all the this is a very bad X-ray lung of that baby. And another baby, this was a success story, but this baby was referred to us about the first week of life. The father was admitted with, the mother was negative, but the father had a severe COVID pneumonia. Unfortunately, the father expired. The baby was referred to us with hypoxia, respiratory distress, put on NIV. We saw the second tier inflammatory markers were elevated. This baby was started on dexamethasone, and at that point we again gave remdesivir. But luckily, this baby responded. It was a term baby. Baby responded to our treatment, and we could discharge the baby after around 15 days. So these were the only real two cases where we had a severe COVID-like presentation in our neonates. Majority of our other babies had only mild symptoms, or positive babies were asymptomatic. And those other one or two babies who we lost were due to, as Shanavas sir said, was other reason. One had a critical congenital heart disease, or that was the reason for the mortality. So thank you again. So it is always better to be prepared for an emergency, and we are really worried whether the next wave will bring out more and more cases of severe manifestations of COVID in our neonates, and whether the MISC-N entity will be a growing and various different presentations. Like even we had a baby, if you have a baby with a high drops or unexplained causes, again you will have to suspect if you are ruled out other causes, because we don't know, this is an evolving disease, what is going to be the presentation. So it's always better to be ready with the manpower and resources and all the equipment, and hopefully it will not come to that. Thank you all for patient listening.
Thank you, Dr. Radhika, for a lucid presentation. We all covered all the aspect of COVID and miskin newborn also. So they have a lot of questions. One my personal question to the Dr. Radhika, because here the situation, these are the peripheral level. Suppose how the peripheral medical officer or pediatrician can be safely tackled, because suppose a scenario comes, the patient mother is again positive, baby or 10th day or 40th day by mother is positive, baby test is positive, whether that baby and mother can be counseled in such a way and they can be keep in that peripheral level or at the home isolation if they're having asymptomatic.
If the baby is asymptomatic, what we do is that if the positive baby is referred to us, even if the baby is asymptomatic, we make sure we observe for at least 48 hours, make sure the baby is okay, and then we discharge the baby home, telling them what is the symptoms they have to look for. And if there is some telephonic follow-up or some way they can contact us, and if there are any worrying symptoms. So in an asymptomatic baby, after observing and telling them the danger signs, there is no harm in discharging them or keeping them under home isolation. It does not require hospitalization, but they should definitely tell them that what are the symptoms, because it can be, sometimes it can just be lethargy, and our preterm baby, the fever may not be a very common presenting symptom in neonates. So it can be any other form. So poor feeding, lethargy, anything they feel that the baby is unwell, they should be told to bring the baby back to the hospital.
Another scenario commonly in our general peripheral pediatrician facing is the IUGR babies. What is up to what weight, what any weight criteria to keep their like a routine IUGR baby managing the periphery, or any specific for a COVID and IUGR babies?
Sir, the indication for admission is usually less than 34 weeks, or what we are following is 1.8 kg. If the baby is less than 1.8 kg or less than 34 weeks, the baby will definitely require some monitoring and assessment in the initial few days. And all other admission criteria are same for any other neonate. For low birth weight, otherwise there is no difference in that. So a baby less than 1.8 kg or 34 weeks will definitely require admission.
Shano, sir?
In the chat box, there are some questions, of which one you have already answered. What are the common symptoms we can expect in a newborn?
Yes, sir. I said it may we are also just studying about this disease. We don't know how it is going to evolve, but fever is not very common. But it can, what we have seen is it may be mild. It can be mild tachypnea can present. It can present as poor feeding, lethargy, apnea, even encephalopathy or seizures has also been reported. So it's a wide varied presentation. So if you are not able to account this for any of our other common diagnoses, first and foremost diagnosis in a newborn is sepsis. So if you have ruled out sepsis or hypoglycemia or other illnesses, then you will have to think of COVID in this present scenario.
Second question regarding vaccination. How will you give routine immunization in an asymptomatic positive neonate? I think
there it can be as per normal. There is no change. We can give all the routine vaccination. What I just interestingly came upon is this tocilizumab. I don't know where it is not recommended in our for neonates. That is the only one where they said that OPV and the rotavirus vaccine is contraindicated. But anyway, we are not using that for our neonates. So other than that, no other contraindication. Only thing is, if the baby is preterm or the baby needs an ICU stay, we usually delay the BCG and OPV. Otherwise, asymptomatic babies, you can give as all vaccines as per routine.
Another question is, does the diagnosis of miss in newborn needs positive IgG or IgM?
Yes, so one of the diagnoses is the presence of even though baby is RT-PCR negative, transplacental IgG positivity is one of the requirements for diagnosis of miskin neonates. But many times we have practical difficulties in getting the IgG done. Now we are doing, but earlier when our initial babies came, it was not easily available to us, so we were not doing at that time. But and the documentation, the criteria for diagnosis does recommend the presence of IgG in the serum of the baby as well.
Okay.
What is the hypoxia criteria? Any difference when pediatric and newborn? Any hypoxia criteria for admission and Dr. Sir?
If actually below 90 is a criteria, sir, in neonates what they are seeing for respiratory support, and a target saturation of 91, because as we would do in the NICU, a target saturation of 91 to 95 preductal in the right upper limb would be what we are aiming for. If you are doubtful between 91 to 95, the baby is having respiratory distress, again, that baby may require some form of respiratory support. So below 95, you have to keep a watch out.
Can you already you discussed everything? Can you recap what is the indication when you will start steroid in a COVID positive newborn? When you give any other medication like a remdesivir or any other indication for remdesivir pediatrics concern now at present newborn?
We have very limited experience, so whatever experience I know is only from reading from protocols. So only 2 cases we have had to manage, and actually we were just learning with those 2 cases. Though what we have done is after we tried our routine supportive care for the babies for the initial 3 to 4 days, but when we saw worsening of the picture on the X-ray and the baby was needing invasive ventilation, we went for steroids, and for the term baby we used dexamethasone, and the preterm baby we used hydrocortisone, because there were initially some reports that hydrocortisone is preferable in preterms, and the duration can vary from 5 days to 14 days as per the clinical course of the baby. So a 1-week treatment with steroids, if there is a worsening of the X-ray findings and if the inflammatory markers are becoming positive, is what is recommended. But again, there are not many clear-cut guidelines in this, because the number of cases of severe COVID infection in neonates which are reported are very, very few.
So another question is from periphery. What are the danger signs of referral to a tertiary center for a COVID positive neonate?
Danger signs, I feel, should be the same as for any other neonate. So any baby who is sleeping for more than 6 hours, or signs of excessive sleepiness or lethargy, a baby refusing feeds for no other cause, and a baby who is having fever, definitely temperature instability, and bleeding manifestations, and apneas. A preterm baby, many reports are talking about apneas and heart rate abnormalities. Even that Miss Ken paper that came out, one of the common manifestations for them was bradycardia. So these are the common things. So danger signs would be that: cold peripheries, poor feeding, lethargy.
So will you give BCG on day 1 in a newborn COVID positive baby's mother?
If the baby is asymptomatic, as per a routine protocol, within 24 hours, you can give BCG. If there are no other logistic issues, there is no contraindication. Only if the baby is symptomatic or admitted in the NICU, we defer it.
So next question is shown in the presentation. How many newborn turned positive so far in SAT for a positive month?
So in the initial wave, our inborn positivity rate was around 4%. 4%, it was low. Overall positive babies, that is including outborn, but outborn it's very heterogeneous. So it is generally all the studies so far have reported a positivity rate of less than 10% only. So we've got 4% positivity rate, and we are just analyzing a second wave. But again, when I looked into it, out of the 377 babies, I think only 15 had a positive within the first 48 hours.
Does the inflammatory markers like ferritin and D-dimer important? If they are very high, should we treat?
This is a second tier investigation. We have had to send these investigations, as I said, only for 2 of our babies. But this again, the reference cutoffs for newborns are not very clear. because again, there might be the inflammatory cutoffs which are given for newborns. We are extrapolating from pediatrics and older people. So definitely the markers, when the values come, we don't know what for sure whether they what is the correct cutoff. So again, a lot of new evidence is required, and unfortunately, we're not facing many babies who needed second-tier investigations.
Again, on personal experience, I think babies of a COVID positive mother, whether they are presenting with high counts, neutrophilia, negative CRP, RT-PCR negative, and abdominal distension, got settled down within 2 days. Is it secondary to positive COVID mother?
It could be, sir, because if the mother is baby is negative, but if we could have a serology, then maybe we know. But first and foremost, bacterial sepsis has to be ruled out. That is the most common diagnosis. If that is ruled out, if the IgG is positive, it could be because of a transplacental passage.
Another question is a COVID positive baby with more than 5,000 D dimer. Is it necessary to start Clexane?
I don't think we should go by the values of D-dimer again in a newborn, but clinical presentation, if there is a risk of thrombosis, like sometimes the coronary artery aneurysm, or the case report which I showed, or limb ischemia. Otherwise, routine use of aspirin, enoxaparin, just based on the lab reports, is not recommended so far.
So another suggestion is whether oropharyngeal swab is better than nasopharyngeal in newborn.
No, all the recommendations talk about nasopharyngeal only. Nasopharyngeal is the recommended. Earlier they were talking of both, but now the current guidelines all talk about nasopharyngeal swab.
Okay, so far, so these are the questions. Anybody else wants to ask a direct question? Can ask.
Can unmute and ask question, direct questions. Next, sir.
Dr. Radhika.
Yes, please.
Hello. Any case of IgM positivity among the tested newborn babies?
No. Actually, we have not got any IgM positivity, ma'am. No
Sick
IgM.
babies. No. Okay. Thank you. Excellent talk. No?
Thank you so much. If there other centers will also like to share their experience, sir, Shanava, sir.
So we had in the first spread, we had one patient came with very severe shock, and we were forced to send the patient to Amrita. Subsequently, they turned out to be the first MISC in newborn. They have reported in some journal also. So we at that time our cardiologist was off. We were not able to do an echo, and we directly sent the patient to Amrita. So we don't have any loss, but even no need for any severe treatment. Requiring patient was also not there. We had enough patients with COVID positive mothers. Jairam, any other anything else you want to add? Pramida, Jairam.
Ramla, sir.
Only that case which we have sent back to home, and after day 16, patient came in shock and have differential cyanosis, and we suspected coagulation of aorta and something. We referred the case to the same case as that Shana was telling, and from there the IgG was positive, IgM was negative, and they suspected as COVID. I mean MISC. And they treated the baby, and baby survived. They have given IVIG from Amrita.
So I think all unusual presentations, now we should keep a lookout now, because all mothers who are having COVID positivity during pregnancy, then we have to, if there is some unusual presentation, we have to keep out and keep this entity in mind.
Another problem we are facing is routinely for ultrasound, for MRI, etc. We are doing the test, but the problem is the baby may be positive, but it may be sepsis or something. So we can't say whether the symptom is because of sepsis or COVID positivity.
Yes, sir. That's
accidentally turning out to be positive.
Yes, sir. That is there. And now actually one of our major problems we are facing is because many of the mothers are pregnancies being terminated prematurely. We have 29 weekers, 28 weekers because the mother is sick due to maternal indications. So our COVID SNCU has a lot of sick preterm babies, not sick, they were all COVID negative, but they are being, because the mother is positive, you need to man them. So difficulty in adjusting the manpower and resources, because sick preterm babies being admitted, we cannot keep them in the general NICU. And only once 2 swabs are negative, we will shift them to the main NICU.
Another point I want to stress is if the mother is receiving medial prednisolone, which will not cross the placenta, when you are doing preterm cesarean, you have to give dexamethasone or betamethasone. Otherwise, the lung maturity will be affected.
Yes, sir. Yes, sir. With dexamethasone, actually the newer guidelines are recommending dexamethasone. And mother can, after the antenatal steroid for lung maturity, it is dexamethasone which is recommended, the same dose.
Hello, Dr. Radhika, excellent presentation. I enjoyed.
Thank you so much, sir. Thank you.
Anyway, this talk and listening to this talk, it gave me a lot of insight into what are the things to be procured, what are the things to be kept ready. When the pediatricians asked me, what are the things to be kept ready? Thank you for that.
Anybody want to ask any question? Anybody want to ask any question?
Kumar sir left.
Kumar sir boy.
Okay. So in that case, I think you can, Jose, you can wind up.
Doctor.
Jose, നമ്മുടെ ലേബർ റൂം ജോസ്.
പറയ്.
നമ്മുടെ താഴത്തെ ലേബർ റൂമിലെ മദേഴ്സിനെ കിടത്താൻ വേണ്ടിയിട്ട് കൂടുതൽ സൗകര്യമില്ല. അങ്ങനെയാണ്, അവിടെ കുറച്ച് സൗകര്യം ഉണ്ടെങ്കിൽ ബേബീസിനെ അവരുടെ കൂടെ തന്നെ കിടത്തായിരുന്നു. അതിന് എന്തെങ്കിലും ചെയ്യാൻ പറ്റുമോ സാറോടൊന്ന് ചോദിക്കാം.
അല്ല ശരി, അത് വേറെ ഡിസ്കസ് ചെയ്യാം. അപ്പോ how early can you get a MISC in newborn? Is it usually transplacental? One question is there.
It can present at any time after birth. So in the first 28 days, it can present it because the mother may have had a past infection. She may not be COVID positive at the time of delivery. So even in the immediate neonatal period, if it is due to the transplacental, it can present as MISC also. Most of the case reports I've read is the median age of presence is around 1 week or 2 weeks, around that time. But even earlier, it can present.
Okay, thank you, Radhika. And Dr. Reshma is sir. Reshma.
Sir, ഞാനുണ്ട് sir.
Thanks പറഞ്ഞേക്കെ.
It is my pleasure to give the vote of thanks. Thank you, Radhika madam, for that very elaborate presentation. It was very useful. And I would also like to thank Joe sir and Shanavas sir for moderating the session. And I would like to thank Ramlal sir, who, in spite of his busy schedule, could attend the meeting. Suma madam, Padmakumar sir, DMO madam. I would like to thank all the senior faculty members who took time to attend the meeting, and also all my friends and colleagues who attended the meeting. I'm sure this might have benefited you a lot. And in next week, we will have COVID in pediatrics. Thank you all and good night.
Thank you. Thank you.
Next week is respiratory management by Dr. Shija. I think everybody should come for that also. So next Wednesday.
Dr. Ramla sir, you want to say something? Ramla sir?
ഒന്നുമില്ല. Thank you. Thank you.
Thank you very much.
Good night.
Thank you.
Good night.
Good night.